Like, what? Where's the OBGYN? Like, what are they doing? What are they doing? What? I'm so pissed. Yeah, interesting. This is ridiculous. I'm getting so irritated by this. All right, let's get started. HBO. The Pitt. It is episode 5 o'clock p.m. Okay, so instead of putting p.m., we usually use military time in the hospital, but anyways, I'm Dr. Rachel Southard, and I'm a second-year OBGYN resident physician, and today I'll be reacting to an episode from The Pitt. A lot of you guys have said that there is a particular scene that is OBGYN related, and I'm very excited to react to this. I know that a lot of medical shows, they're not actually very accurate because they're just over-glorified and oversimplified at the same time for the sake of TV. I have heard a lot about this show, but I've honestly never seen it because I'm a resident and working upwards of 70 hours a week, and then also I live this every single day, and I need a break from it. I don't want to watch a glorified show about it. So here we are. We're going to react to it, and let's just get started. Bear with me. I've never done one of these before, so let's hope it goes smoothly. I'm on nights right now, and I actually have to go to work in a few hours, so I'm definitely not going to watch this whole episode. Here it is. I'm just looking for a pregnant person. Here's a pregnant person, and let's go.
Natalie Malone, 35-year-old G3P2, 39-week pregnancy and active labor after a trauma.
All right. I'm pausing right there already because let's just break it down so we're speaking the same language. He says G3P2. What the heck does that mean? G stands for gravidity, so how many times has someone been pregnant? So she's been pregnant 3 times. The P stands for parity, so that means how many times has she delivered? It's a little bit more complex than that because you can break it down further for how many full-term deliveries she's had, how many preterm, how many miscarriages, and then actually how many living children that there are. But again, at the same time, this doesn't actually tell you the mode of delivery. So was it a C-section? Was it a vaginal delivery? But he says G3P2, so I'm going to assume, just for the sake of the show, that she's a G3P2002. So meaning that she's had 3 pregnancies, 2 deliveries, no preterm, no miscarriages, and then she has 2 living children. I'm just going to assume that because yeah. The next part of the report that he gives is that she's in active labor. So the cervix can go from 0 centimeters, that's being closed, all the way to 10 centimeters. And 10 centimeters means they're fully dilated, they're ready to push. You're not in active labor until you get to 6 centimeters. And so 6 centimeters and beyond, active labor, great. This is telling me that she's at 6 centimeters or more. And typically when you have a multip patient, a multiparous person, that means they've had multiple pregnancies, multiple deliveries. They tend to move a lot quicker in their labor compared to someone who it's their first time being pregnant and being in labor. It doesn't necessarily change our management, but we just know that, okay, this person's probably going to move quicker. So let's get her in a room. Let's get her checked, all of these things. The next thing that he gives in report is that she's schrammed, so spontaneous rupture of membranes. That means that her water broke spontaneously and she's here showing up to the emergency department. Let's continue.
It's not my first time. All right, let's get her into trauma.
She says it's not her first time.
And then we'll send her
Clearly,
up to labor and
she's
delivery.
a G3P2.
Doctor,
okay, this would never happen in our hospital. First off, when there's a paramedic or EMT or whoever bringing in someone by ambulance that is known to be pregnant, far along, and or in labor, they typically come immediately up to labor and delivery. They don't spend any time in the emergency department. They have no business being down there. So unless it's like a car accident situation, but someone who's like brought in by ambulance because they're in labor, they're ruptured or whatever it is. So usually they come right up, or we're already like downstairs in the emergency department waiting for them. Strange that they would even put her in a room to evaluate her prior to just bringing her up to labor and delivery, or I don't know. Why aren't the OBGYNs already down there?
It's nice to meet you.
Moving along.
Any problems with the pregnancy? Well, 3rd time's a charm.
Okay. When you have someone coming in huffing and puffing like this, you're wanting to get as much information from them as quick as possible. And you don't necessarily have time to like sit there and go through their chart, because what if they're about to deliver? Obviously, other healthcare staff are pulling up their chart and getting that information for you. But in that moment, I'm like asking them, what's wrong with this pregnancy that you know of? Have you had C-sections in the past? Have you had vaginal deliveries? What medical conditions have you been diagnosed with in the past? And specifically, I want to know about high blood pressures like chronic hypertension, that or asthma, because those particular conditions impact what medications we give should this patient have a postpartum hemorrhage. You're wanting to get quick information off the bat from the patient, and you just straight up ask them and hope that they are reliable in that way. Meanwhile, your team is also pulling up that information for you to confirm it or provide more information.
Justin's pretty nervous though. This is his first time. Don't push. Just breathe. Check her, Dr. King.
That definitely must be the resident the way that like the hierarchy is, like check her, meaning like go check her cervix to see how dilated she is. I don't think an ED physician would be doing that necessarily, because first off, they should be upstairs already with the OBGYN team. But then also it takes a lot of practice to actually know what a cervix feels like, because if she's not fully dilated, which I presume that she's about to be, it is hard for you to know like what a cervix at like 2 centimeters, 3, 4, 5, 6, it's hard to know. Where's the OBGYN?
Natalie, you're crowning. Call L&D.
Why is she down there? This is the last thing that an ED doc would want to be doing, delivering a baby in the emergency department. Like, where is the OBGYN? Okay.
What do we got?
39 weeks, crowning after
Snaps
a
the glove like that. Weird. Okay, I think this is like the main guy in this show. Where is
Okay, Natalie.
the team?
Good chance we'll deliver on the next contraction.
Bulb suction is ready.
Head is out.
Nice. Take a break. Catch your breath.
We'll
before
keep
the next-
pushing. What do you mean take a break before the next one? Okay, no. After the head's out, like you want to deliver that baby. If the head is not coming out, you're concerned, like why is the rest of the body not delivering? Like where are the shoulders? This is clearly going to be a shoulder dystocia episode. This is not it. Why are they waiting for the next contraction?
Another big push.
Okay, I'm forwarding. I'm getting so irritated by this. Like, why are you just delivering the head and letting it sit there? Like, what? You have no idea how that baby's doing. They don't have fetal heart rate tracing, no nothing down there. What?
Another big one.
You said that the last 2 times.
You're telling me that they've done 2 contractions and they haven't delivered the rest of the body yet, and just the head sticking out?
Shoulder dystocia.
This is ridiculous. Okay, that's the
That's called the turtle sign.
the turtle sign.
don't-
That's because that the anterior shoulder, the front shoulder of that baby is getting caught under the pubic bone. And so when they push, they're pushing and it's just stretching that baby's like neck and shoulder, and then they suck back in, and then like they just keep doing this turtle thing. I mean, in an ideal setting, you want to know like the weight of this baby beforehand, but you know, oftentimes when someone's coming in like this, you don't know. You can put your hands on the belly and do a Leopold maneuver. And that's essentially you trying to feel and the size and weight of this baby. You can also go by ultrasound and extrapolate what the weight might be off the most recent ultrasound. Sometimes that's not always available to you, blah, blah, blah. You're just like alerting the team already, like this might be a shoulder dystocia. Get more people in the room, get stools next to the bed so people can stand on them and assist with the maneuvers.
Can I ask you to bring down a fetal monitor, please?
Just now bringing a fetal monitor down. What? Like, this patient should have been upstairs already. A fetal heart rate monitor would already have been placed on her abdomen. This makes no sense. I'm actually like, my heart rate is so high right
Might be a
now.
little stuck on your
A little
pelvic bone.
stuck.
It's nothing for you to worry about. We'll just try something different on the next push.
The fact that
Ready?
they're...
Why don't we all take a deep breath, huh? Everybody.
I need to take a deep breath. They're just letting this head chill here. A shoulder dystocia is an emergency. The cord is being compressed, the umbilical cord, so they're not getting oxygen. And then also their chest is being compressed and they cannot breathe if their like head's already delivered. If you're not actively trying to get that baby out and you cannot after like 3 to 5 minutes, like that's the absolute max. I'll get into that. Why aren't we moving along, and where's the OBGYN? So that's the first thing that you do with a shoulder dystocia. Immediately, McRoberts maneuver, you flex the hips as much as you can and basically point the vagina to the ceiling, because that opens the space of the pelvis to hopefully get that anterior shoulder to slip under and deliver the baby. A lot of times you can get a shoulder dystocia resolved with McRoberts, but then obviously there are other maneuvers for a reason that you have to start going down the chain if that doesn't work. So the next step is usually suprapubic pressure, which sometimes can help, sometimes doesn't do much. Okay, so they're lifting the knees.
Suprapubic pressure here. Pressing on your bladder.
Yes, okay, you're pressing on the bladder, but you're actually, so the person down at the perineum delivering the baby needs to know which side the infant's back is on. And so if their back's facing the maternal right, then you want to have your person that's doing the suprapubic pressure to stand on the mom's right, and you're essentially having them press on the infant's back to try and rotate that shoulder down and out from underneath that pubic bone. And so that's what they're doing with the suprapubic pressure.
2 minutes since her delivery.
2
Fetal
minutes.
heart rate looks good. Normal variable.
Yeah, interesting. It's been 2 minutes since head delivery, and they're just doing the Mick Roberts and suprapubic pressure. And then they have a fetal heart rate monitor saying that the heart rate looks good, moderate variability. That's not the only thing that we're looking out for when we're looking at a fetal heart rate. There's multiple components. But maybe they're also decelling and the heart rate is going down because they are being smashed and not getting any oxygen through that cord.
You're doing great, Nat.
Feel free to step in and take over.
I'm like so annoyed.
Give me a big push.
Okay, Natalie, here we
And
go.
the Toco, the Toco, great, up high. But the Doppler, the Doppler that's on the abdomen is completely upside down. There's no ultrasound gel on that. It's upside down. And also, why is it on her left lower quadrant? That baby is so low that if you're going to get a fetal heart rate, it's going to be like on top of the pubic symphysis because the baby's so low. So typically when someone's delivering and, whether or not they're actually in a shoulder dystocia or if the baby's just taking a long time to deliver, the nurse will move the Doppler down to get the heart rate because it's going to be super low, like right on top of the pubic symphysis because the baby's low. The baby is not up here anymore. They are lower. The Doppler is upside down. Fantastic.
Late decel.
A late decel. Okay. A late deceleration means that there's a dip in the heart rate after a contraction, and that's indicative of placental insufficiency. This baby is not getting oxygen during a shoulder dystocia. Where is the OB team?
His heart rate has slowed, which could be a sign of distress.
Could be a
What do we
sign of
do?
distress. A shoulder dystocia is an obstetric emergency. Like, what?
We deliver this baby.
Yeah, you
We
need
got
to
this.
deliver this baby. Like, what
We
are
got
they
this.
doing? What are they doing? I'm sweating.
Eusebio, can you please the OR and tell him to prep for a possible crash C-section?
Yeah, because they know how to do a crash C-section. Right. Where's the OB team? I'm forwarding. I can't watch this because it's so inaccurate. I'm so pissed.
Little burning.
There again with the upside down Doppler. Love that. He's doing a posterior arm release. Posterior arm release is my favorite to do for shoulder dystocias. Like after the Mick Roberts, I typically will just go for the posterior arm immediately. And so you essentially just reach in. You have to stick your whole hand, like you're typically up to like your wrist. Hang on, I need to put my mic here. So when you're doing a posterior arm release, you're putting your whole hand inside the vagina to grab, and you're trying to feel whether you can get to the humerus or you're actually trying to get more to the forearm or wrist of that baby, and you're trying to pull them up and across, like externally rotate across the baby's face to get the arm out of the vagina and deliver the arm, because at that point then you can have this kind of like, yeah, they have more space, and that anterior shoulder will typically release from underneath the pubic bone, and then you can deliver the rest of the baby like that. That's what he's trying to do.
OR is prepped and ready. Do we need to go up?
Do we need to go up? I get that this is a show surrounding around emergency medicine, but this is a decision that will be made by the obstetrician, not by the ED physicians. And why isn't she in there doing what she needs to do to deliver this baby? And why is she leaving it in the hands of the ED physicians to release a shoulder dystocia? Not that they can't do it. Maybe they can. Maybe they're trained to do shoulder dystocias, but it takes so much practice. And like, you have to know how to do these. Like, you have to have done them many times to know what you're doing. And I don't think that this happens every day in an emergency department.
All right, there's the elbow.
So they're
Church
flexing the
flex?
elbow and then gonna like externally like rotate it to deliver it.
Oh, and
Okay, I'm not quite sure what he was doing, because he was actually doing like a Rubens or wood screw maneuver, basically like corkscrew the baby around.
yeah, baby boy.
I've got a stubborn set of twins upstairs, admitted to postpartum.
And then the OB
Congratulations, everyone.
just dips. What? Like, what? Why?
1 minute Apgar is 3.
Isn't Apgar supposed to be 9 or 10?
An Apgar is a score that a baby gets at delivery. 1 minute, 5 minutes, and then if it's under a certain score at 5 minutes, then they will also do 10, 15, and sometimes 20. It's an acronym. So the A stands for appearance, P stands for pulse, G stands for grimace, A stands for activity, and then R stands for respiration. They get either 0, 1, or 2 points. There's a total of 10 points that a baby gets. So I bet you're wondering, like, what happens if I can't resolve the shoulder dystocia after I have done Mick Roberts, suprapubic pressure, posterior arm release, Rubens, wood screw, You typically will start over again and try to go through those things again. If not, having someone else, if there's another physician available, sometimes just having a different set of hands can help release it. Try that. You go through maneuvers again. There's another maneuver that is not included here, but the Gaskin maneuver. So putting a patient on their hands and knees, that can open the pelvis to deliver the baby. Sometimes this can unintentionally happen, but other times it actually can be intentional if you really just need to deliver this baby. It's been a lot of time, but you can break the clavicle, one or both. So essentially you just reach in and you hook your finger under the clavicle and break it, because that will make the diameter of that baby smaller. Sometimes that has to be done. It's obviously not something that we're doing. First off, sometimes it happens unintentionally. So if I know that a baby is big, or if they've had a shoulder dystocia in the past, I will consent them upon admission when it's obviously like a controlled admission, and I will give them like the shoulder precautions and consent to say, hey, I want you to know that these are the specific maneuvers that we do. We're just trying to resolve the shoulder dystocia as fast as possible and safely to make sure that baby comes out okay. Every second that the baby is not getting oxygen is opportunity for baby to have brain damage. So I know that having a broken clavicle or humerus or having nerve damage sounds very scary. These things will heal on their own, or if it's nerve damage, it can be permanent, but it can also be temporary and resolve. But would you rather have that than have a baby that is dead or has severe brain damage and cannot function? It's not a conversation that is fun to have, but I just like to let the patient know ahead of time, like, these are the things that we might have to do. And sometimes if patients have a very big baby, we will recommend a C-section instead of a vaginal delivery, and for those very reasons and the risk of a shoulder dystocia. Because in the end, if you cannot get that baby out and it has been 3 to 5 minutes of you trying, someone else has tried, you've done all of these things over and over, and you're not getting that baby out, you need to either push the baby up and go to a C-section, as that's called a Zavanelli, or something that I personally would never do, but you can also cut the pubic symphysis in half and deliver the baby that way. I do not know how to do that. I would personally never do that. I would rather go to a C-section, but also like every second that you're going back for a C-section, getting the baby out is more time that they're not getting oxygen. So it's a very serious event that happens. And so the fact that it's being managed in an emergency department and everyone's just like chilling and waiting for the next contraction type thing this is not realistic at all. So now they're waiting for the placenta to deliver, and this you can give up to 30 minutes for the placenta to deliver. You're massaging the uterus externally to try and get the placenta to release, and then you're also giving traction on the umbilical cord. You have to be careful to not shear the cord and have it rip completely off of the placenta, because then you have to go and manually extract the placenta. But the first signs of a placenta separating from the uterus is when the cord will lengthen, you'll get a gush of blood, and then you know the placenta is trying to deliver.
Oh, wow.
What?
That's a lot of blood.
The pregnant body has a lot of blood reserve for delivery. Like specifically, this is how the body has evolved. The blood volume expands of a pregnant person because of how much blood loss happens at time of birth, or can happen at time of birth. So the maternal body will have a reserve for this. Postpartum hemorrhage is not considered a full hemorrhage until this patient reaches 1 liter of blood loss. So it's a lot. It's a lot. It can happen very quickly. So when you start seeing a gush of blood come out after the placenta delivers, you are starting to actively manage already to prevent a postpartum hemorrhage, because they do have a lot of reserve, but they can bleed out very, very quickly.
Starting uterine massage, 40 of oxytocin in the back, 800 mics of sublingual misoprostol, and 1,000 of TXA.
So she's giving Pitocin right now. So Pitocin is, the typical urotonic agent that is a first line that you give with delivery. A urotonic is what helps the uterus contract down. And so they're giving that. She said sublingual misoprostol. So this is a medication that also helps with the uterus contracting down. She's giving TXA, which is an agent that helps prevent the breakdown of blood clots. So she can just clot all of her blood. What else is she doing? Getting blood on hold.
Call OB and get Robbie. Massive PPH on MTP and all
PPH is postpartum hemorrhage, and they're getting the urotonics, obviously. Carboprost is Hemabate, and that is an intramuscular injection that you give. And so if someone has had a history of asthma, or they have asthma, you don't want to give this medication because it can cause a bronchospasm, and then you've created another problem. Hemabate also gives diarrhea. So with Hemabate, I also always ask the nurses to give 2 of Lamodal, because Lamodal will help prevent their explosive diarrhea that will quickly happen after Hemabate. But obviously during a postpartum hemorrhage, the last thing you're worried about is diarrhea.
I am, and get a Apgar balloon from Central.
A Apgar balloon is like, it's like a tube that you put up inside the uterus and then you fill it up. So it is now a big balloon and it's pressing on the sides of the uterus. At our hospital, we typically use a Jada, which is this device that you slip up into the uterus and then you hook it up to suction. And then it is like sucking the uterus down to it to help it just contract and stay tight and small. The main cause of a postpartum hemorrhage is from uterine atony. So the uterus, it is a muscle. And if it's relaxed, all of the arteries and vessels like of the uterus are just open and bleeding. So you need that muscle to contract down to squeeze those arteries so it stops bleeding. You want to do a bimanual massage, which what she was doing. You have your hand up all the way to the fundus of the uterus internally, and then on the outside you're also massaging to help the uterus contract underneath your hands. You want to give uterotonic agents, have blood available, and then you start thinking of like a balloon to put in or a Jada. If she is still bleeding at that point after you've done everything and she's still bleeding, you might have to go to the OR and potentially do a hysterectomy. I didn't hear her give Methergin. I don't know if they're going to do that or not. But Methergin is another uterotonic, but you cannot give it if they've had elevated blood pressures currently or in the past, because it'll make their blood pressures really high and then you create other problems.
How much should we put in? Up to 500? If that doesn't work, she'll need a hysterectomy.
I think we did it.
They cured her.
No
And
more blood loss.
why the heck wasn't the obstetrician doing it the whole time? I don't know. That's the end of the OB part. I'm sweating and I'm so stressed and I smell like stress sweat and I have to go to work in like 20 minutes. I hope this doesn't happen to me tonight. By all means, I'm not bashing on emergency medicine physicians. I'm just saying that the show is inappropriately showing the roles of an ED physician in a laboring and postpartum patient's care, because you don't see this, at least to my knowledge. So I really want to hammer home the point that shows like this, they're glorifying medicine, and medicine is great, fantastic. But if you're basing your desire to go into the medical field based on shows like The Pitt or Grey's Anatomy, you might find yourself very disappointed to find that there are a lot of things that are not being shown that, you know, also play a role in medicine and like our jobs and profession. Just take these shows with a grain of salt and watch them for entertainment, but don't base your idea of what it's like being a healthcare provider on shows like this. But anyways, that's just my little 2 cents. And I hope you guys enjoyed this video. It was really fun to do. If there are other episodes or shows that you want me to do a reaction to that relate to the field of obstetrics and gynecology, I would love to comment them down below. Subscribe if you're not subscribed. Join our herd. We're happy and a great time, and we would love to have you. So until next time, take care of yourselves, be kind to yourselves, continue to work hard and all the good stuff. Okay, bye.